Today we have the fourth neuroradiology discussion session. We have an interesting set of cases for discussion today. I would like to introduce the moderators for today's session. Sneha, can you please share the CV slides? So we have Dr. Sameer Vyas, sir. He is the professor of neuroradiology in the Department of Radio Diagnosis from PGI Chandigarh. Sir has several publications to his credit, and he has authored several chapters and books. And his areas of interest are neuroimaging and interventional neuroradiology. And another moderator of this session is Dr. Arushi. Arushi doesn't require any introduction in this group. She is a pediatric neurologist and she's the associate professor of pediatric neurology in the Department of Pediatrics, PGI Chandigarh. Her fields of interest are neurodevelopmental, neurometabolic, and neurodegenerative disorders. She has won several awards, and she also has several publications in national and international index journals. Over to Dr. Arushi.
Thank you, ma'am, for those kind words. So we'll quickly begin with the session. Today we have cases, two interesting neurometabolic disorders and one neuromuscular disorder, which significant neuroradiological changes, and the presenters would be our DM residents. The cases would be presented by Lieutenant Colonel Abhishek Pandey and Dr. Santosh Mishra. Both of them are pursuing their DM pediatric neurology at PGI Chandigarh. So over to you, Dr. Abhishek, for the first case.
Right, thank you, ma'am. Am I audible?
Yes, you are audible.
Am I audible?
Yes, Dr. Abhishek, you are audible.
Good evening, everyone. So without much delay, let us dive in with the cases. So our first child is a 3 years female child, a female girl who presented initially to us at the age of 8 months with a febrile illness followed by multiple episodes of generalized tonic-clonic seizures. Following the seizures, she had encephalopathy and regression of milestones, after which she started showing slow improvement. When she was referred to us from a peripheral hospital, and when she came to us, she was mildly encephalopathic with brisk TTRs. There were no meningeal signs, and her head size was normal. There was no dystonia or ataxia. So based on the historical aspects, we kept a possibility of acute febrile encephalopathy, immune-mediated CNS involvement versus a neurometabolic. We went ahead with investigations. The first test which was done was CSF, which was normal. EG was done, which shows multifocal IDs, and neuroimaging was done, which will be discussed. So we received these neuroimages are of recent, when she's 3 years of age. The previous images are not available with the patient. So this will be discussing at 3 years of age, the present neuroimaging findings. So we have numerous films which were available with us, and from the we'll move on from the chaos to order in a patterned approach. So this is the MRI of our index child. So first question, when we receive an MRI which looks like somewhat like a leukodystrophy pattern, when we see the first impression which we get, we have to go in a patterned approach. So first question to sort is whether it is a gray matter involvement predominant or a white matter involvement predominantly. So based on this, when we see our index child images, it's quite clear that it's predominantly a white matter involvement. Now, whether it is a hypomyelination versus other white matter pathologies. So if it is hypomyelination, it is mild T2 hyperintensity combined with T1 hyperintensity oblique T1 isointensity. While if it is other than hypomyelination, like demyelination or dysmyelination, it will be prominent T2 hyperintensity and prominent T1 hypointensity. So if we look at our index images, child images, we can see in the T2 weighted, they are prominent T2 hyperintensities and T1 hypointensity. So it was white matter, predominant white matter involvement apart from hypomyelination. So second question when we are looking at something like this is whether it is a symmetrical or an asymmetrical involvement. So as seen in the index child, it is clear that it is a symmetrical involvement. See, both hemispheres are almost symmetrically involved. So it just gives a pointer that probably we are dealing with a genetic inherited disease and not an acquired disease, though there are some exceptions to all rules. So these are examples in which symmetrical involvement can be there, and there can be multifocal oblique confluent. So the third is pattern of white matter involvement. So the pattern which can be followed is whether it is a centripetal or a centrifugal involvement. So centripetal means from periphery to center. So in, this is an index case in which we see clearly that the peripheral white matter is much more involved than the central white matter, and the periventricular sparing is prominent. So there is periventricular sparing, there is centripetal involvement from outward to inside, and predominant subcortical involvement. Okay, so we are dealing with a white matter involvement, something other than hypomyelination, which is bilaterally symmetrical and is going in a centripetal manner with prominent periventricular sparing and predominant subcortical involvement. So till now things are clear that probably we are dealing with a white matter disease which is probably inherited. Then next question is gradient. We look at the gradient. So whether it is anteroposterior or posterior anterior. So it is very clear from the image that it is predominant in the anterior frontal lobes and less prominent in the occipital lobes. So we have a gradient from anterior to posterior. So these are all signature markers by which, just by looking at the gradient of the white matter changes, we can reasonably come to a conclusion. Obviously other things are also required. So then next question is additional MRI features. So which are many, but what our child had was prominent dentate nucleus involvement. The cerebellar white matter was spared, and along with white matter involvement, we also had basal ganglia involvement, predominantly involving the caudate, the putamen, the globus pallidus, and we could also see some hyperintensities in the thalamus. So other features which we need to look also is evolution over time. We didn't have the initial MRI images at 8 months. Otherwise, we could have looked into the evolution of the lesions with age. So now we have come to a conclusion that probably we are dealing with a white matter disease, which is not a hypomyelinating type, which is bilaterally symmetrical, confluent, anterior to posterior gradient, involving the subcortical white matters. Periventricular white matter is spared. Basal ganglia is also involved. However, thalamus is largely spared, and dentate nucleus is involved. So so we have come to some conclusion that what are the MRI findings which we are dealing with. So this is Vandernaap's paper 2009, in which it shows that how can we deal with white matter pathologies. So we came to a conclusion that we are dealing with something other than hypomyelination. It is a confluent lesion and it is a subcortical predominance. So very few differentials are left with this pattern of MRI images, which includes L2OH glutaric aciduria, Kearns-Sayre syndrome, Canavan's, propionic acidemias, and urea cycle defects. So the most common mimickers will be a Canavan's, in which it will present in early infancy with macrocephaly will be a prominent sign. There will be visual impairment. The white matter involvement will be subcortical predominance. However, no frontal predilection will be seen. Globus pallidus and thalami are predominantly involved. Caudate and putamen, those which were predominantly involved in our child, are characteristically spared, and also dentate is spared in them. The brainstem may be involved. In Kearns-Sayre, again, the presentation is different. They present with ophthalmoplegia, deafness, ataxia, sometimes cardiac conduction defects. Again, subcortical predominance is there. However, the globus pallidus, caudate, thalamus are usually involved. Putamen is less commonly involved, and brainstem are usually involved. So the index child, as I discussed, has a bilateral symmetrical subcortical T2 hyperintensity, subcortical involvement, centripetal involvement, caudate nucleus, putamen, GP prominently involved, thalamus mildly involved, dentate is involved, cerebellar white matter is not involved, and brainstem is spared. So the pattern-based approach, we have come to some sort of conclusions. Probably we are dealing with an L2HGA. It is a rare disease. However, we went on with next set of investigations. We sent a urinary TMS GCMS, which showed a peak for L2HGA, confirming our radiological correlation. Now, L2HGA is a rare metabolic disorder, and the clinical course is usually very slowly progressive disease. They present with ataxia, spasticity, then sometimes they present with febrile seizures, and more often than not, later on, they sometimes develop intellectual disability. So our child had presented with febrile illness followed by seizures. So a line about L2OH. So it is basically just a metabolite repair enzyme. This L2OH doesn't have this L2OH doesn't have defined physiological functions in our body. It is just a metabolic byproduct. And when this enzyme L2 hydroxyglutarate dehydrogenase is absent, the L2OH accumulates, and this accumulated L2OH results in oxidative brain injury secondary to myelin vacuolation. So this is a cohort of Indian children cohort in which we see that many of children present early, 1 year, 2 years, 4 years, 5, 3, 2 years, and this our index child probably fits somewhere here. A female of 7 months present with febrile seizures, and she is showing improving course. So classical MRI findings, what we have discussed already: subcortical white matter involvement, periventricular spared, symmetric, periventricular mostly spared, and cerebellar and brainstem is never involved. The gray matter involvement, dentate is involved in 100% cases. Chordate putamen are invariably involved, and one important thing is laminar sparing is present in the globus pallidus. Thalamus was involved in very rare cases. Our case has thalamic involvement. The described thalamic involvement is paramedian. However, we have an anterolateral involvement of the thalamus. So this is a graphic presentation of the gray matter involvement percentage of cases. So we can see clearly that dentate, chordate, putamen, and globus pallidus are almost always involved. Thalamus is very rarely involved. So this is the book pictures. Now we saw classical MRI pattern in case of L2OGA. Now we'll go into deviation from norms. What can happen? What are other patterns which we can see? So when L2OGA presents in acute stage, classically we saw it is symmetrical. In acute stage, there can be an asymmetry. There can be diffusion restriction. The cortex may be involved. Deeper white matters may be involved. The plic and corpus callosum may be involved in acute presentations. So as we can see, there are 10 cases, 8 non-acute and 2 acute, in which asymmetric involvement is, though the number is very less, only 2, but both the cases have an asymmetric involvement. They have cortical involvement, restriction, diffusion restriction is present, and deeper white matters, unlike the non-acute cases, is involved in all cases. So this differentiates acute from non-acute. Now, something which also adds on is an NNA reduction, which can be seen in MR spec. And lipid peak can be seen during active demyelination. The NNA reduction is predominantly attributed to axonal loss secondary to spongiosis. Now, next is MR abnormality, which can progress with disease duration. So we saw how an MRI can be seen in early infancy and in first 2 to 3 years, how an MRI looks during an acute presentation versus a chronic MRI. Now we'll see how the MRI evolves over time. So this they have from the following article, we see they have put images of children at various ages, and as we can see, this confluency increases as the age advances. The white matter abnormalities become more confluent. They become more symmetrical bilaterally. Initially, they can be multifocal. They become more confluent as the age advances, and the anteroposterior gradient also slowly disappears. Also, obviously, the frontal predominance always remains, but as we see as the age advances, the occipital white matter was also involved. So from multifocal, we move to confluent. From subcortical, we move to deep white matter involvement also. From frontal, we move to global. So this is how the MRI evolves over time. This is again representative images of a child which shows gradual advancement with age. And here we can see the periventricular deep white matter is also involved. Okay, so another difference is the involvement of the basal ganglia. Now, as we see at younger age, the basal ganglia, the caudate and the putamen shows peripheral rim enhancement. The caudate and putamen are showing peripheral rim enhancement, and the globus pallidus is homogeneously involved. This pattern is gradually lost, and as age advances, the globus pallidus, the caudate and putamen start becoming homogeneously involved. So with looking at the caudate and putamen, we can guess the age of the disease. So initially, as we can see, the caudate and putamen are peripherally enhancing, and as age advances, the caudate putamen start becoming involved homogeneously. Also, along with age, there is significant atrophy which sets in, and also we can observe ventriculomegaly. Last point regarding L2H is its oncogenic potential. It has been found that probably it has a carcinogenic potential. And since it is a slowly progressive disease, most of them live into adulthood, and some of them have been found to have malignancies. The following are the malignancies which have been found in L2H hydroxygluturia patients. So take home messages, as I have already iterated, Professor Samir sir will be discussing it again. There are characteristic MRI images which prompts us, as in this case, to go ahead with an TMS GCMS, and which made us come to a conclusion. The child is doing well. She doesn't have any deficits, and she's absolutely fine. We examined her just a week back. Thank you.
Thank you, Dr. Abhishek. I now invite our expert from neuroradiology, Samir sir, to summarize the salient features of salient neuroradiological features of this disease for our audience.
Yeah.
Over to you, sir.
Thank you, Dr. Arushi, and good evening, everybody. Abhishek has described very nicely all the pertinent points, the features of the disease with the disease duration and the characteristic imaging findings. And he has also discussed the brief the approach to neurometabolic disorder. So I suggest to have a patterned approach to neurometabolic disorder. Like in this disorder, we should always begin with whether the predominant gradient, like in this, the predominant finding was the subcortical leukoencephalopathy. And then we go ahead with looking the other findings, like the involvement of the globus pallidus, the putamen, the caudate, the deep gray structures, the thalami, the brainstem, and cerebellum. We should have judge on all the deep gray structures or a characteristic imaging findings of all, and then slowly and ruling out all in a systematic way. So in this disorder, the characteristic imaging finding described are subcortical leukoencephalopathy with involvement of the basal ganglia, diffuse, and the dentate. There initially the disease, there may be the frontal preference of the disease, but with duration it may maybe become a more confluent. And few related points which may help is the relative sparing of the brainstem and cerebellar white matter, which may be seen in other diseases which Abhishek has told. And two other important is we should look in is a periventricular rim in diseases like the L2-hydroxyglutaric aciduria, the Canavan disease, the Kearns-Sayre, and HMJ coli, which Abhishek has not discussed. This is also a differential diagnosis of the subcortical leukoencephalopathy. And spectroscopy, though described in the literature, we find it less useful because these are non-specific findings like decreased NNA and lipid. They are mostly non-specific, but they complement the diagnosis and may be supportive, but in isolation, they should not be included in the making a diagnosis of some particular disorder. So just to sum up, we should have a patterned approach by taking seeing all the spectra of the disease, and then reaching at a particular diagnosis by including few of the involved areas and which are characteristic of a particular disease. And as pointed out, L2-hydroxyglutaric aciduria has a very characteristic neuroimaging finding and can be diagnosed with very certainty, especially in the early stage of the disease. And maybe at the later durations, the findings are non-specific and may be confused with other disorders. So this is just a radiological summary from my side.
Right, sir. Thank you, sir. And we'll quickly move on to the second case. We'll be taking up the audience questions at the end of the all the cases. So I now invite Dr. Santosh to start sharing his screen and begin with the case.
Abhishek, I think you should stop sharing the screen, then only Santosh can show his screen.
Is the screen visible?
Yes, your screen is frozen, I think. You can stop sharing your screen and then restart. Then reshare your screen.
Right, ma'am. Ma'am, is it visible?
Yes, yes. And you're audible too.
Good evening, everyone. So proceeding to the case. So we have a 12 months boy, premorbid normal development, presented to us with the acute febrile episodes that later proceed to the encephalopathy and altered sensorium. Later, the child also developed generalized tonic seizures and followed by an acute neurodegeneration. Otherwise, past and family history were not contributory. On examination, child had a microcephaly, and at the time of examination, child had an encephalopathy and was not recognizing the parents. There was intermittent generalized dystonia with central hypotonia, and deep tendon reflexes were brisk with bilateral Babinski sign. So we kept the clinical possibilities of a CNS infection, parainfectious, and neurometabolic. And on investigation, we performed CSF, which came to be normal. So our possibilities of infection was ruled out. And in the first type metabolic workup, all workup came normal: ammonia, lactate, blood gas, and TMS and GCMS. On MRI, this is a T2 sequence, T2 exit sequence of the child, which is showing basically a high signal changes. High signal changes in the symmetrical and diffuse high signal changes in the caudate nucleus, putamen, as well as a globus pallidus. As we go deeper, we can see there is an involvement of a bilateral cerebral peduncle. And in the posterior fossa, there is also involvement of a bilateral symmetrical dentate nuclei. And as we go in the upper section, similar signal changes is seen in the basal ganglia, and plus there is also signal changes in bilateral symmetrical deep white matter. In T1 image, myelination looks normal as per age, and along with that there is a low signal intensity in the distribution as shown in the T2 weighted image, and other morphology seems to be normal. In the FLAIR image, there is a high signal intensity in the distribution as shown in the T2 weighted image both in the basal ganglia as well as in the brain stem, as well as in the posterior fossa, that is a dentate nuclei, as well as in the upper section of deep white matter. So in the T1 axial contrast, there is no such contrast enhancement. However, in the diffusion restriction image, there is a high signal intensity. There is a diffusion restriction in the distribution of the same areas of that the basal ganglia, of the midbrain, of that of the posterior fossa, that is dentate nuclei, as well as in the deep white matter. And as evident by the ADC, there was a lower signal intensity in those corresponding areas. In the susceptibility image, there is no such susceptibility changes that is suggestive for the hemorrhage or any metabolic deposition. So as we can see by this video, so we have a child with the MRI showing the changes basically in the high signal T2 flare high signal changes that is involving the basal ganglia and the dentate nuclei, and as well as deep white matter and the cerebral peduncle. So, so today's topic will be a radiological approach to the basal ganglia disease. So for the in the anatomy of basal ganglia, we know that it has been divided into the corpus striatum, that is basically formed by the chordate nucleus and the putamen and the globus pallidus, and there is other areas of subthalamic nucleus as well as substantia nigra. So we'll be discussing the radiological approach to the basal ganglia disease, mainly focusing on the T2 hyperintensities and the susceptibility changes. And T2 hyperintensities will divide it into the anatomical site, like a striatum involvement, globus pallidus involvement, and the combined involvement. So if there is a striatum involvement, then the our diagnosis will get narrowed to a organic acidemia, the mitochondrial, and the other causes like Wilson's and hypoxic ischemic encephalopathy. So in organic acidemia, basically in the glutaric aciduria, there will be an involvement of a striatum, as well as there will be a widened fissure, bilateral symmetrical, as well as there will be the extra axial space will be widened. So this is the signature of signature radiological imaging of a glutaric aciduria. And in the mitochondrial Ley syndrome, Ley-like syndrome like MELAS, biotin thiamine responsive basal ganglia disease are the likely cause which will involve the striatum. And as we can see in this T2 axial section, there is an involvement of a central part of the central part of a chordate nucleus, as well as the putamen is involved. And however, thalamus is also involved, and the subcortical regions are also involved. In the hypoxic ischemic encephalopathy, this is basically insult to a high metabolite area. So there will be involvement. However, in the later stage, that might not be seen in the radiological imaging, but there will be additional encephalomelastic changes, as well as a oligaric pattern, that is a mushroom-like projection. So this will be suggestive for the hypoxic ischemic encephalopathy. So this mitochondrial and Wilson and hypoxic ischemic encephalopathy, along with the striatum, they also can involve the thalamus. Another is the involvement of a combined striatum as well as a globus pallidus. I have categorized this into the organic acidemia, that is L2OS glutaric aciduria, propionic acidemia. L2OS glutaric aciduria has already been discussed in the previous session. Another is a sulfide oxidase deficiency, molybdenum cofactor deficiency, mitochondrial, like again Lake syndrome, and the PDX complex deficiency, and the white matter disease, leukodystrophy like Alexander disease, and metachromatic leukodystrophy. So in this image of axial section, we can see there is a complete agenesis of a corpus callosum. And in this axial section, we can see there is an indistinct basal ganglia. We can't differentiate the basal ganglia anatomy here. And along with that, there is asymmetrical ventricomegaly and with subependymal cyst bilaterally. So these findings are more suggestive to other PDX complex deficiency. For the Ley syndrome, there is a wide range of anatomical site that will be involved. It is a multifocal involvement. So there is, as we can see in this axial cut, T2 cut, there is an involvement of a chordate nucleus along with the putamen. In the subsequent image, we can see there is involvement of putamen as well as a globus pallidus. Bilateral symmetrical diffuse substantia nigra is involved. Periaqueductal area is involved. In this medulla is showing diffusion restriction. Similar, the symmetrical involvement of a dentist nucleus can be seen. Cortical involvement, patchy cortical involvement can be seen. Deep white matter involvement can be seen, as well as spinal cord. So it is basically multifocal. So Lake syndrome will present with a multifocal involvement, as well as a combined striatum, as well as a globus pallidus involvement. Talking about the isolated globus pallidus involvement, so once we have ruled out the kernicterus or carbon monoxide poisoning, then our diagnosis will be narrowed to a methylmalonic acidemia, cerebral creatine deficiency, that is a GAMP deficiency, and some variant of a pyruvate dehydrogenase deficiency. So in this T2 axial cut, we can see there is a bilateral globus pallidus hyperintensities is seen. So this is a classic for the methylmalonic acidemia. And if in the subsequent year, if we'll repeat the MRI, then we can also see a cystic changes. And similar changes can also be seen in the cerebral creatine deficiency. when there is involvement of a globus pallidus along with the white matter, then our diagnosis should be Kearns-Sayre syndrome, maple syrup urine disease, and a Canavan disease. In Kearns-Sayre syndrome, basically there will be early involvement of a subcortical white fiber. However, there will be sparing of a periventricular white matter, and there will be involvement of, as we have discussed, globus pallidus, and in this image there is also involvement of the posterior limb of an internal capsule. So the earliest involvement of the subcortical white fiber is the entity for the Kearns-Sayre syndrome. As in the other disease like of that lysosomal, peroxisomal, the subcortical white fiber involvement will be late finding. And in this Canavan disease, it has already discussed, there will be along with the white matter tract involvement, there will be involvement of a globus pallidus as well as a thalamus. However, striatal part will not get involved. And when we do a spectroscopy, there will be a peak of a N-acetyl aspartate. So now, when the globus pallidus is involved along with the cerebellar dentate, so apart from the diagnosis which we have already discussed, succinic in the white matter, succinic semi-aldehyde dehydrogenase deficiency will be added. And in the succinic semi-aldehyde dehydrogenase deficiency, it has been reported that there will be involvement of a pallidal dentate tract. So basically, there will be involvement of the symmetrical globus pallidus, as well as there will be involvement of a dentate, or if the imaging has been done in the juvenile SSADs, there might be a cerebral or a cerebellar atrophy. If there is a globus pallidus along with the depth of the sulcus is involved, then the likely diagnosis would be urea cycle defect and organic acidemia. So the scheme for the MRI protocol should be, in the step 1, we have to do a conventional MRI sequencing like T1, T2 to look for the any pathology. And in addition, we have to go for a GRE as well as SWI to look for any calcification or a hemorrhage. If we are thinking about some diagnosis where white matter or cortex is involved, then contrast enhancement should be done. In acute stage, if the presentation is very early, so in that acute stage, we can even go for a diffusion weighted imaging, which will show a restriction, a diffusion restriction just because of the cytotoxic edema or and myelin edema of the white tract. Advanced methods are there like MRS, magnetic resonance spectrometry, which will show the accumulation of a metabolite in the part that is basically affected, and the diffusion tensor imaging to look for the white fiber tract. And the most important is the regular follow-up and observation, because sometimes just a myelination or a normal brain maturation will be thought like a pathology in the T2, and so we have to repeat the image in the regular follow-up. And sometimes if the disease presentation is in the early stage, then there might be just subtle changes or maybe no changes at all. So in that condition, we have to repeat the imaging in the later year. So in a brief, I'll be talking in a brief on the susceptibility changes. So whenever there is susceptibility changes in the basal ganglia structure, and there is involvement of a globus pallidus, substantia nigra, and the subthalamic nuclei. So now we have to look for the hypomyelination. So if there is hypomyelination, so our diagnosis will be a beta propeller associated neurodegeneration or Copen syndrome. If there is optic atrophy, then our diagnosis, probable diagnosis would be a plateau 6 neurodegeneration or a Kofer-Rakov syndrome. If there is a cerebellar atrophy, then the diagnosis will be narrowed to a mitochondrial protein associated neuropathy, neurodegeneration, or a plateau G6 associated neurodegeneration, or a juvenile Parkinsonism, that is a Kofer-Rakov syndrome or a Cohen syndrome. If there is a striatum involvement, then our diagnosis should be acerebroplasmonemia, Wilson's disease, neuropharinopathy, hypermanganesemia, that is SLC30A110 mutation, basal ganglia calcification, and Kofer-Rakov syndrome. So in our index child, in genetic, in whole exome sequence, there was a homozygous mutation of a ALDH5A1, which basically encodes the tetrameric succinic semi-aldehyde dehydrogenase. So there will be a and for the parent segregation was done, and in that both the parent was a carrier, And so talking briefly on the pathophysiology, so basically ALDS 5A1 will encode the succinic semi-aldehyde dehydrogenase. So either it will be completely absent, or there will be a less function of a succinic semi-aldehyde dehydrogenase. So when there is no succinic semi-aldehyde dehydrogenase, succinic semi-aldehyde will not get converted into succinic acid. So the byproduct like 4-hydroxybutyric acid and 4,5-dihydrohexanic acid will form, and these are excitatory neurotoxic agents. So the typical MRI pattern as described by the literature is the pallido-dentato-Lucian pattern. That is, there will be involvement of a globus pallidus and dentate nucleus, and along with some subthalamic nuclei, subcortical white matter, and brainstem. As we have already discussed, in the juvenile SSADH, there might be a cerebral atrophy or cerebellar atrophy. However, in our index case, there was involvement of a basal ganglia structure, not only the globus pallidus, also the striatal part symmetrically and diffusely. And also there is an involvement of a deep white matter and cerebellar peduncle. So apart from the what has been described in the literature, this striatum was also involved. So there are certain atypical patterns that has been described in the literature. This case report was done in the 2011, where they have reported a case, a child of her who initially presented at the 4 months of her age with a hypotonia and the developmental delay. However, when MRI was done at that time, that turned out to be normal. And then on subsequent imaging at 8 months of age, that showed basically a putamen involvement. And when it was repeated again after 1 year, there was a diffuse atrophy of the caudate nucleus. There was those high signal changes were there in the putamen, and there is a diffuse cerebral atrophy. So another case report was done in the 2014 from the China, where they have described the cerebral atrophy at presentation. So there was a diffuse cerebral atrophy, and they have also, along with the bilateral putamen changes, along with that there was also a subdural hemorrhage. So this subdural hemorrhage has been described in the other metabolic conditions like Menkes disease, glutaric aciduria, then homocystinuria, but not reported to the SSADH. So these are the atypical patterns. Even we also had a case in our center where the child present, when we did an MRI on the child, there was a cystic changes that we can see in this flare image. There is a suppression of a high signal that has been actually seen in this T2 image that has been suppressed in the flare. So there was cystic changes in the bilateral globus pallidus as well as there in the substantia nigra. So this pattern of this radiological pattern has not been described in the literature. So my take-home message is whenever for the radiological basal ganglia changes, T2 sequence and SWI based sequence is necessary. Anatomical approach can help in narrowing down our differential diagnosis. Though individual disorder can have a spectrum of changes, but we have to remember the typical pattern, but we have to move from the typical to atypical pattern as well. Though rare, SSADH is one of the prototypic disorders with bilateral globus pallidus changes. Thank you.
Thank you, Dr. Santosh. I now invite Sameer sir for his expert comments on this case.
Yeah, Santosh, you nicely described the case, but in contrast to the first case, the findings in this case was not classical of what is described in the literature. But as we go by the case, if we follow the patterned approach, then we can reach at some particular disorder that what we are discussing. In basal ganglia, as you rightly pointed out, two important things we should, in addition to the T1, T2 changes, we should always see the SWI changes and the diffusion changes. The contrast enhancement that does not usually we do in a neurometabolic disorder, though few findings have been shown in few cases. So in basal ganglia disorder, in addition to the patterned approach, we should follow the what we can call a clustered approach. Like we cluster the findings into what they describe like isolated globus pallidus involvement, or the involvement of any of the basal ganglia structures along with the like GP with the striatum, globus pallidus with the cerebral peduncles, globus pallidus with the thalami or a dentate. So in this patient, though atypical, this patient has the involvement of the whole of the basal ganglia, the cerebral peduncle and the dentate, and the mild involvement of the parieto-occipital white matter. So in considering all the differential diagnosis, the SADH comes in a differential diagnosis, but though not typical. Again, the radiological literature has been described GLX peak in such cases, but they are only means of interest when it's done in a proper setting, and we're looking at a particular disorder. So in addition to what I've discussed, we can look into the GLX peak at 2 at low T values, and they may help or complement our diagnosis of this rare entity. So that's all for this case.
Right, sir. Thank you. And I now invite Dr. Abhishek to begin with the third case. Dr. Abhishek, can you start sharing your screen?
Good evening, ma'am. Share. Is my screen visible, ma'am?
Not yet.
Is my screen visible, ma'am?
Not yet, Abhishek.
Ma'am, now?
Yes, yes. Now we can see your screen.
Sorry for the delay. So we move on to the third child. My slides are not moving. So we have a 2.5 years girl child born out of a non-consanguineous marriage. She had presented to us with delay in achieving milestones and with a swelling noted at the back of the head since birth. She had a significant antenatal history in the form of two second trimester abortions on the mother, and antenatally she had been diagnosed with hydrocephalus with meningocele. So on examination, she had characteristic facial gestalt. She had a dolichocephalic head. She had long eyelashes. She had a depressed nasal bridge. There was a small occipital encephalocele present. She had a small head. It looked like larger, but her head circumference was around -3 z-scores. She had characteristic eye findings. She has constricted pupils, nystagmus. She had a squint. Neurological examination was she was hypotonic. Her reflexes were brisk. There were no contractures. There was mild scoliosis present, and her fundus showed tessellated fundus, which is seen in myopic eyes. So we went on. So a hypotonic child with developmental delay with encephalocele prompted us to go ahead with a CK-NAT, which was high actually in this case, 617. So the constellation of symptoms were delayed milestones, eye abnormalities, occipital encephalocele, raised CK-NAC levels. We thought probably we are dealing with something to do with muscle, along with involvement of the brain and some ocular abnormalities. So This is the paper which we looked into, and there were multiple diseases which can present like this, predominantly the congenital muscular dystrophies. They're predominantly of 3 types: collagenopathies, merissenopathies, and dystroglycanopathies. And our child probably fitted into this particular group of dystroglycanopathies, which present since birth. There is hypotonia. Cardiac involvement was not there in our child historically. CNS involvement was there. However, she did not have any history of seizures. However, there was cognitive involvement present, and eye involvement was prominent. So with the phenotype of a possible muscular dystrophy, we went on with brain MRI and ophthalmological examination. So on looking at this MRI, first thing which we see that we find a thickened cortex, a listen cobblestone pattern of cobblestone finding on the MRI. So what is so when we find a delayed child with raised CK, with ocular abnormalities, with a cobblestone pattern, initially it was said as lissencephaly type 2. So we have very less differentials. So we come to congenital muscular dystrophies with dystroglycanopathies, and probably we are dealing with either one of the 3, Fukuyama's, muscle eye brain disease, or Walker-Warburg. So there are other neuromuscular diseases which can be associated with brain malformations. However, our child had typical characteristic findings which fitted into a congenital muscular dystrophy. So neuroimaging showed cobblestone lissencephaly, which I already reiterated that it brings down the differentials to very few, and it predominantly happens because of the cobblestoning is because of over-migration of the neuroblasts. So these are all images of our index child. I have shown a few of them for the presentation. So in this, we can see there is cobblestoning in the cortex present. It is a thick cortex, and there is ventriculomegaly, and prominently we can see cerebellar vermis hypoplasia. So there is a cobblestoning in the cortex, there is cerebellar hypoplasia and ventriculomegaly present. The cerebellum was hypoplastic, there was vermian hypoplasia, and there were cerebellar cysts present. If you can see, there are multiple cerebellar cysts which are present here. Then we move on. The cerebellar cyst also visible in the sagittal section. The corpus callosum was dysgenetic, and the pons and brainstem were hypoplastic. It was very slender. Classically, the brainstem is described as Z-shaped in congenital muscular dystrophy, Walker-Warburg phenotype. Ours was not classical. However, we can see that the dorsal brainstem is concave. So there is a pontomedullary dorsal kinking present in the brainstem, which has been described in congenital muscular dystrophies. So as you can see, the dorsal brainstem should be a straight line. However, in our case, you can see a typical concavity. Also, there were parenchymal cysts present in the temporal lobe. This is the encephalocele. There is an atretic encephalocele. No brain tissue is herniating through it. It was a small encephalocele. This is the physical finding, and this is the MRI image which you can see. We can also appreciate the ventriculomegaly, the thin corpus callosum, the cerebellar hypoplasia, the thin pons medulla, and the encephalocele, the bony defect which is seen here. So Walker-Warburg is characterized by profound hypotonia, severe ocular abnormalities, progressive macrocephaly. Our child had microcephaly, and posterior encephalocele. And there is diffuse cobblestone lissencephaly pattern in the MRI. What are the characteristic ocular findings in Walker-Warburg? There are anterior and posterior abnormalities. Our child had squint, pupils were small in size, there was tessellated fundus, and there was coloboma which was visible on the MRI. This is a representative case in which colobomas can be found out in the MRI in the form that anterior-posterior diameter of the orbit is increased, and we can see the vitreous pouching through the posterior segment defect. So we reviewed few articles in which we found that there are characteristic findings of Walker-Warburg syndrome on MRI, and almost all of them are present in our index case: cobblestoning, fused colliculi, small pons, dysmorphic mesencephalus, dorsal pontomedullary kink, vermian hypogenesis, cerebellar hypoplasia, microphthalmia was not there, hydrocephalus, and posterior encephalocele. So these are representative images. We can see cobblestoning, we can see hydrocephalus, we can see posterior encephalocele, and we can see this dorsal kink present in the pontomedullary in the brainstem. So From the clinical features to brain MRI, we found out symptoms, the features suggestive of a congenital muscular dystrophy, probably a alpha-dystroglycanopathy, and so we went ahead with genetic testing. And as we can see, we had a clinical suspicion of Walker-Warburg in the requisition, and rightly so, we found a POMT1 gene mutation in house panel. So various genetic mutations have been described in alpha-dystroglycanopathies. Our child had this POMT1 mutation. The one of two lines on POMT1 gene, it encodes for the enzyme protein O mannose transferase, which is a key enzyme in glycosylation of alpha-dystroglycan. And the phenotypic severity depends upon the residual enzyme activity. So it is found in both the muscle, the brain, and the eyes. So we have these three constellation of symptoms. So we can see this is the alpha-dystroglycan, and in presence of hypoglycosylation, what happens is there is reduced ligand binding. So it cannot connect the intracellular to the extracellular cytoskeleton. So what happens is there is disruption of cell matrix interaction. And as a result of this destruction of cell matrix interaction, what happens is this, as the neurons are migrating along the brain, toward the brain surface, they over migrate because there is discontinuity of the pial basement membrane. And as a result of discontinuity of the pial basement membrane, what happens is these neurons over migrate and they result in finding of cobblestone. Listen carefully. So all these findings were present in our case, which pointed towards a probable POMT1 related mutation. And this is a large study in which 27 families were studied and all had this classical ophthalmologic involvement, this classical MRI findings, cobblestoning on the MRI, and encephalocele. So if we follow a patterned approach in a case of muscle disease involving the brain, then we will reach to a particular diagnosis. So take-home messages are good clinical characteristics. Like in this case, we found that the muscle is involved, the brain is involved, the eyes have classical clinical findings. We went on ahead and the first test which we did was a CK, which was raised. So we thought we are dealing with some muscular dystrophy. That is why we went ahead with the MRI. MRI findings was pointing towards a Walker-Warburg phenotype. Then we went ahead with a clue to the geneticist that we are probably suspecting this, and we found out a POMT1 mutation. What I want to highlight is that this child in utero had a hydrocephalus and an encephalocele, and if ultrasound is done clearly, we can also detect ocular findings in the ultrasound, and this is a strong diagnostic clue towards a POMT1 mutation. Another two important points: complex brain malformations, which do not fall into specific categories of monogenic disorders, and early CK-NAC can be a simple diagnostic, not diagnostic, can give us a clue how to move ahead. And again, unexplained cognitive impairment with muscular weakness and microcephaly and early CK can guide us to better, more appropriate investigations. Apart from the previous, these are the references which I had used to make this presentation. Thank you.
Thank you, Dr. Abhishek. And over to Sameer sir for salient features in this case.
Abhishek have very nicely shown all the spectra which was seen in this POMT1 mutation case. So in a radiologically, the most important in such cases when come is to recognize the radiological phenotype. So what is the predominant anomaly? Characterize it clearly, like this is a cobblestone, listen carefully, and then look for the other associated findings from the corpus callosum to the brainstem, cerebellar involvement, and all. In this patient, it was a characteristic finding of a cobblestone lesion carefully with corpus callosum dysgenesis, and there is a pontine and a brainstem hypoplasia with a cerebellar vermean hypoplasia. So radiologically finding were very, and in addition, as shown, there were cerebellar cysts, and on the left side there was a suggestion of a cerebral dysplasia also. So they were very highly suggestive of us congenital muscular dystrophy, like likely the Walker-Warburg syndrome. So there may be these findings of the brainstem or there may be sometimes non-specific if a few of the findings are seen. But in the index case, since the findings were very characteristic, the cortical findings, so logically it's straightforward. But sometimes only a part of the findings are seen, like only the cerebellar cysts or a brainstem isolated findings are seen. Then maybe with differential diagnosis, and then we have to do the other investigations. So just to conclude, in such cases, if we recognize the radiological phenotype clearly and identify the associated feature, then we can arrive at a diagnosis with a quite certain.
Thank you, sir. Thank you, Dr. Santosh and Dr. Abhishek, for the excellent cases. We'll take a few questions. Can you please elaborate on the laminar sign seen in L2-hydroxyglutaric aciduria? Dr. Jyotsna has posted this question.
Abhishek, would you like to answer or should I answer?
So I'd request if you could.
Okay. So we have an internal and external medullary lamina separating the globus pallidus internus from the globus pallidus externus, and that from the putamen. So if we can see the sparing or a T2 hypointensity interspersed between the globus pallidus internus and externus, that's in a few of the articles that have been shown to be a characteristic involvement of the fever disorder. And additional, what Abhishek showed, the characteristic peripheral putaminal hyperintensity, that is an additional sign of the L2-glutaric aciduria. So if we can show the laminar sparing or the T2 hypointensity interspersed within the high signal intensity of the globus pallidus, that may be suggestive of L2-hydroxyglutaric aciduria.
Thank you, sir. And in patients with Fukuyama muscular dystrophy can also have similar MRI changes. So how will you differentiate radiologically between these three syndromic congenital muscular dystrophies? Are there any radiological clues?
Logically, there are many significant overlap findings. There is no one-to-one correlation. We have to see which is predominant abnormality pattern, and then we have to go for the genetic analysis. I know we cannot clearly discriminate between these. We can suggest a pattern of the involvement, but differentiating between each identities is not possible in the imaging part.
Sure, sir. In patients with L2-hydroxyglutaric aciduria, since they are at risk for malignancies when they grow up, how periodically are we supposed to do a screening MRI on these patients, sir?
There is no definitive guidelines, but at least yearly or after 2 years, they should be screened routinely for just a T2 flare. That's sufficient enough. But yearly, they should have just a non-contrast screening MRI in the form of just T2 and flare images.
Even in patients with L2-hydroxyglutaric aciduria, there are atypical presentations which has been discussed during the case discussion. So they can have an asymmetry and one hemisphere more involved with more of white matter involvement on one side. So if you have a tumor of underlying tumor transformation, so how do you go about it?
Like the changes which are asymmetrical, that the pattern is different from the focal space occupying lesion. So the various malignancies have it, but on imaging, you can clearly discriminate between the pattern of involvement, the white matter or a deep gray structure involvement from the neoplasm, the tumors which are associated with the L2-hydroxyglutaric aciduria. And that too, the asymmetrical findings are described in the early stage of the disease and not in the later stage of the disease. In the later disease, what we see is the end result of the atrophy and the diffuse involvement of the white matter. So asymmetry, as discussed, is mainly seen in the earlier stage of the disease, not in the later stage of the disease.
Sure, sir. And one of the attendees have commented, cobblestone and lissencephaly are different entities. One is over-migration and the other is under-migration. So the term would be cobblestone malformation and not cobblestone lissencephaly.
Agreed. It's a terminology means in type 1, type 2. It's a continuing, and maybe I agree this is a misnomer. It should be rather the cobblestone malformation rather than lissencephaly. I agree.
Vigabatrin-associated MRI changes can closely mimic radiological features of SSADH deficiency. So are there any radiological clues to differentiate between these two, sir?
Pardon? Which one?
Vigabatrin-associated MRI changes can also have a globus pallidus, subthalamic nuclei, and dentate nuclei hyperintensity. So it is one of the closest radiological differential for SSADH deficiency. So are there any clues which we can use to radiologically to differentiate between these two?
Diffusion restriction is seen in the vigabatrin toxicity, and there are usually bilateral symmetrical with a temporal correlation with the drug. So we usually see the diffusion restriction in vigabatrin toxicity. And the pattern in involvement, the globus pallidus is maybe bereavely involved, but it is classically involved in a SADH.
With regard to SSADH deficiency, is there any role for MRS to pick up elevated GABA levels or for hydroxybutyric acid?
Yeah, I just commented on that case because if we just add to, if we suspecting from a structural imaging, then we may add the GLX peaks or GABA peak that may complement a diagnosis, but these are very non-specific, and there is especially a very evolving or a changing spectra of the MRS in initially the first 2 years of the life. So the MR spectra stabilizes after the mostly after 3 years, and adult pattern is achieved. So they should be very read with a caution, and what we are looking for, like if you're suspecting, and then we should do it and look for a particular peak. In isolation, the MR spectroscopy is not useful in characterizing the neurometabolic disorder, except a few like the Canavan or other few which have very specific peak, like creatinine deficiency, which may be useful. But for these disorders like SSADH, which show non-specific findings, or the GLX peak, they may be complementary diagnosis, but they are not diagnostic.
Sure, sir. There's a question for Arushi. In the third patient, was NCS and EMG suggestive of a muscular involvement even before the imaging was done?
Although I have not managed this case, but as far as we know, since our clinical diagnosis was pointing towards a predominant muscle disease, we did not go ahead with NCS and imaging at the outset. So I think the course that was followed in this case was clinical, followed by MRI and a few blood investigations. If later this has been done, I'm not too sure.
Sure. Naveen sir, do you have any suggestions or comments?
No, nothing from my side.
Sure. Thank you, Sameer sir, for this excellent discussion with us with regard to the salient imaging findings of these 3 interesting patients, and also discussing the closest imaging differentials and how to differentiate it. You have explained it in a very nice way. And thank you, Dr. Arushi, for guiding your residents and moderating this session. Thank you again, Dr. Santosh and Dr. Abhishek, for the excellent case discussion. Thank you, everyone. We can conclude the session. Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am.